Okay, everyone, I think we'll get going. Welcome, everyone, to the University of Calgary's Cardiac Science Grand Rounds for January 16th, 2024. This morning, we have a virtual presentation. Dr. John Eikelboom is joining us. John is a professor of medicine and a hematologist at Hamilton General Hospital and McMaster University. He's a senior investigator at the Population Health Institute there. And has an interest in anticoagulation. He runs the Thrombosis Research Group and has published multiple large randomized trials in antithrombotic therapies in arterial and venous thrombosis and infectious diseases. He's well supported from the peer-reviewed funding agencies and has published more than 750 papers. Since 2014, he's listed annually in the Thomson Reuters list of the top 1% of researchers worldwide. And we look forward to hearing John's talk this morning on anticoagulation. Thank you, John. Go ahead.
Terrific. Thank you so much, Andrew. Again, delighted to be here. I've tweaked my presentation a little bit from that which was advertised, but that'll be self-evident as we go through this presentation. My plan is to discuss with you where we're at with anticoagulation in 2024, in particular, the lessons that we've learned over previous years that will guide us into the future. I have a number of disclosures. I've worked with all of the companies that develop antithrombotics, and I also am involved in running an anticoagulation clinic. This is the scene as we are currently in 2024, when we track back through timelines of anticoagulant development, we begin with the drugs that were discovered by serendipity, unfractionated heparin and warfarin, used in clinical practice for many years before we knew how they worked. Then a large gap of about 40 or 50 years, and we saw finally an advance on unfractionated heparin with alternative parenteral anticoagulants. And then even later than this, the post-turn of the century era of direct oral anticoagulants. And we now have a wealth of alternatives to warfarin for long-term oral anticoagulant therapy. Approximately 10 years ago, I co-authored this paper with Hans Christoph Diener and Chris Granger and Werner Hack, in which we expressed the opinion that the king is dead, that is warfarin, and we were into the next Diadochean War. For the Greek history buffs, Alexander the Great, when he died in 300 or so BC, there was a jostling amongst the generals as to who would lead, who would be the ruler of the world, I suppose, in those days. And very similarly, we said, well, warfarin is dead. What is it going to be? Is it going to be a direct thrombin inhibitor or a factor 10 inhibitor? Well, we were absolutely wrong, because warfarin is not dead. And 10 years later, when I put these titles side by side, this is a paper that Jeff Weitz and I wrote and published very recently in Journal of Thrombosis and Hemostasis with the title, Warfarin is Faring Better. Vitamin K antagonists beat rivaroxaban and apixaban in the Invictus and PROACT 10A trials. Quite the turnaround after prematurely expressing victory for warfarin. And just today online, we published a JACC state-of-the-art review when direct oral anticoagulants should not be the standard of care. And if you're interested, as I said, this paper is now online. So that frames my presentation for this morning. I would like to start by discussing with you the areas where direct oral anticoagulants have failed. And not only where they've failed, but to try to get an understanding of why they've failed, to give us insights into where we might go into the future to overcome those failures. I'll move from there to a very brief summary of what I perceive to be the additional unmet needs in oral anticoagulation. And then I'll end with telling a story about factor 11 inhibitors. Factor 11 inhibitors, which have had such a high profile in the medical literature, and particularly in the investment literature, there's been enormous enthusiasm. The question is, are the currently available drugs that target factor 11 living up to the hype? And I'll leave you with some thoughts on that story. But first, direct oral anticoagulant failures. And I've listed here what I perceive to be 5 of the key areas where warfarin has prevailed, where direct anticoagulants have failed. And I'll start with the first to be reported. This is back in 2013, about 5 years after the introduction of DOACs. It took 5 years for this first area to be identified. In 2016, we discovered from the first of the antiphospholipid antibody trials that maybe warfarin should be preferred here. Just 2 years ago, we had the data from the Invictus trial suggesting that warfarin should be preferred in rheumatic atrial fibrillation. Last year, we had the Frail AF trial suggesting that warfarin might be preferred in people who are over the age of 75 and certainly over the age of 80 who are on a vitamin K antagonist. Maybe there we shouldn't be switching to a DOAC, which is something that we commonly do because, or historically we commonly did because of the advantages in terms of intracranial hemorrhage. And then perhaps more speculatively, perhaps warfarin is preferred in people who fail DOAC therapy. And so I'll end here. But let me start with the familiar story of mechanical heart valves. And this is our phase 2 study, which we published in 2013. This is a randomized trial comparing dabigatran with warfarin in mechanical heart valves. This was a very carefully conducted study in which we up-titrated dabigatran to ensure adequate levels. We went to double the usual doses of dabigatran that are used in atrial fibrillation. We included patients with mechanical valves recently implanted as well as long-term. The results were really quite clear-cut. This is the efficacy result. This is a survival curve, and at the top we have warfarin, and below this we have dabigatran. Now, this difference did not achieve statistical significance, but there certainly was a clear contrast in efficacy between the two, an emerging contrast. And this emerged despite the fact that we were using very high doses of dabigatran, which were actually significantly increasing bleeding. Now, one might argue that this trial was stopped too early because the differences weren't, in fact, statistically significant. But when we combine them, or when we look at these data side by side with those of the PROACT-10A trial, we see a very consistent pattern of superiority of warfarin over DOACs. And this is people with an onyx valve randomized to warfarin or apixaban, and a big contrast, warfarin substantially more effective. Event rates in the apixaban group for valve thrombosis and thromboembolism around 3 to 4% at 1 year, which is clearly unacceptable. So what's the reason? Why did warfarin win in mechanical valves over both dabigatran and apixaban? I'm going to present to you some data that were done here, that were generated here, done by Iqbal Jaffa and Jaff Whites. What they did was they took, in the laboratory, they placed valve leafers or Teflon sewing ring segments inside a well in the presence of plasma. They added warfarin to equate an INR of anywhere from 2 to 3.5. They also added dabigatran separately at various concentrations. And this is a summary of their data. On the left here, we have peak thrombin generation. On the right, we have ETP, or endogenous thrombin potential. So two different measures of thrombin generation. The top, we have the valve leaflets. And just to explain, to take you through this, what we've plotted here is the INR of 2 to 3.5, the inhibition of peak thrombin generation, and the equivalent blood concentrations of dabigatran that would need to be achieved to match the inhibition achieved by warfarin. And the take-home message is that we need dabigatran concentrations to be maintained over about 450 or 500 nanograms per mil in order to match the inhibition of peak thrombin levels achieved by an INR of 2.0. And we know that the usual on-treatment trough levels of dabigatran 150 BID, this comes from an updated paper that we've just submitted for publication. This is the range that we would see with dabigatran 150, 33 to 151. There is no way that any of our dabigatran dosing with 150 twice a day would achieve sufficient suppression of peak thrombin generation to match what warfarin does. So this applies for peak, this applies for ETP, this is for valve leaflets, this is for the Teflon sewing ring. The story is very consistent. We would need to push up dabigatran levels to above 300 milligrams twice a day to match warfarin. And even then, it might not be enough. The same story, the same type of experiments, the same story, the same interpretation for apixaban and rivaroxaban. Here we have the range of INRs and the matching range of rivaroxaban concentrations that would be needed to achieve similar suppression of ETP. This is for rivaroxaban, this is for apixaban, and this is rivaroxaban, apixaban for sewing rings. And here are the levels. We would need to give apixaban and rivaroxaban in doses something in the order of 20 milligrams twice a day to match what we achieve with warfarin. Now, why is it that we would require such high doses of dabigatran and apixaban or rivaroxaban? Well, the answer is quite simple. When we think of coagulation, here we have the contact pathway, which is activated by valves. Warfarin blocks the contact pathway specifically upstream. It also blocks downstream the common pathway. Both the 10A inhibitors and thrombin inhibitors selectively block the contact pathway. They don't block this pathway upstream. And therefore, by the time thrombin generation is activated through contact activation, it simply overwhelms these downstream inhibitors of coagulation. Well, that's the easy story, mechanical heart valves. Let's go to the next, that is chronologically, the next area where warfarin proved the winner. And this is antiphospholipid antibody syndrome. And in 2016, the first trial demonstrating that warfarin may be better was published. Since then, we've had 3 more trials. The message is warfarin is better than DOACs in preventing recurrent arterial events in patients with antiphospholipid syndrome. And the mechanism, like mechanical valves is that warfarin's more efficient to block platelet-induced contact activation. And I'll tell you a little bit more about that. So here are the data of DOACs versus warfarin in antiphospholipid antibody syndrome, the data for venous thrombosis. Now, it intrigues me, it perplexes me why we would prefer warfarin for prevention of recurrent venous thrombosis, when really we don't have any evidence that the DOACs perform inferiorly to warfarin, at least for venous thrombosis. These are really tiny trials with very few events, yet our current guidance is do not use DOACs for antiphospholipid antibody syndrome. I can't help but digress for a moment and think where we've gone with guideline recommendations. We somehow think that the rules for generating guidelines are protecting us, but here we have 4 trials, 400 patients are randomized, we have less than 10 events. And apparently this represents high quality evidence that we should not use DOACs for venous thrombosis prevention in this setting. Contrast, COMPASS trial, 27,000 people, 18,000 people randomized to the COMPASS regimen of rivaroxaban plus aspirin versus aspirin. The European guidelines say, you know, it was only one trial and we really can't recommend this, give this a strong recommendation. We need more than one trial. Somehow that's less compelling than this. But that aside, the story about arterial thrombosis is much more compelling. Here we have 4 trials, still very low numbers, but it's 20 events versus 0 events. It seems that warfarin is substantially more effective than DOACs in preventing recurrent stroke in antiphospholipid syndrome. So certainly if you have a stroke and you're diagnosed with antiphospholipid syndrome, warfarin is the answer. Why might this be? Well, we're not entirely sure, but there is evidence that antiphospholipid antibodies activate platelets, and this is a summary nicely summarized in this not top-line journal, but I think the data certainly reflect our understanding of how antiphospholipid antibodies in part do work. And we need to remember that although we tend to separate coagulation and platelets, we're learning over time that they're much more closely connected than we had ever anticipated. And we now know that activated platelets release polyphosphates, which certainly drive activation of the contact pathway. And because warfarin blocks the contact pathway, this may explain why in the setting of antiphospholipid syndrome, where antiphospholipid antibodies activate platelets, that warfarin is more effective than DOACs. Well, that's the first 2 areas where warfarin presents an advantage over DOACs. Let's move to rheumatic mitral stenosis. More recent and perhaps an area that cardiologists are more familiar with. This comes from the Invictus trial. You'll recall the rationale for this trial, that rheumatic heart disease affects over 40 million people, mainly in low middle income countries. About 1/5 of them have atrial fibrillation. There, until Invictus, were no large RCTs of anticoagulation. The majority of these people with AF are not anticoagulated, and those who are anticoagulated, at least 1/3 are subtherapeutically anticoagulated. So it's obvious that if we had an anticoagulant that worked without monitoring, it would be a huge benefit. And rivaroxaban is becoming generic around the world, so an ideal opportunity to improve outcomes in rheumatic heart disease. But we can't just assume that rivaroxaban is going to work as well as warfarin. We have to prove it. So the trial, 4,500 patients with excellent follow-up. The duration of follow-up, 3.1 years. And this most unexpected result. Unexpected for two reasons. First, clearly, vitamin K antagonists are superior to warfarin for preventing stroke, systemic embolism, MI, or death. So clear superiority. We had not anticipated this. But the second is the curves crossed at 18 months. So what could explain this finding? If we look at the results in a little more detail in the ITT analysis, now the on treatment is exactly the same, so it's not a matter of compliance. There was a clear excess of the primary composite, 8.2% versus 6.5%. I'm just showing you the hazard ratio here. I know that the curves cross, so the proportionality assumptions are not met, but in fact, it makes no difference to the result. So we'll just stick with the hazard ratio. So a 25% excess of this primary composite, driven almost entirely by the excess mortality, 8% versus 6.4%. And we see here 110 events different. Now, ischemic stroke also higher in rivaroxaban than warfarin. The difference here is, what is this, 20-something events, so 26 events or so, a hazard ratio of 1.53. Bleeding was in favor of rivaroxaban, both for major as well as, I should say, for major, including both fatal bleeding and non-fatal life-threatening or intracranial bleeding. So how do we explain this result? It's clearly not explained by a difference in stroke, because it's 26 ischemic strokes prevented versus 110 deaths. It's not explained by bleeding, and remarkably, the difference in mortality was driven entirely by heart failure and sudden deaths. And this effect was delayed. So again, how might we explain this? And I remember sitting at the European Society of Cardiology meeting, seeing these results come through, and as a group, we were racking our brains how this might be explained. And in the process, looking up the literature, trying to understand how warfarin might affect outcomes through pathways that we were not familiar with, we stumbled across the story of tissue-level vitamin K dependent proteins. In particular, one that came to light was GAS6, the growth arrest 6 vitamin K dependent protein. We now know from a secondary analysis of a heart failure trial that the higher your baseline GAS6 level is, the worse your survival, both all-cause mortality and cardiovascular mortality. We also know that GAS6, which is inhibited by warfarin, interacts with the TAM receptors, the tyro3, the AXL, and the MERTK, this family of receptors. These receptors are upregulated in cardiovascular disease and obesity. GAS6, a vitamin K dependent protein, interacts with this AXL receptor, and protein S, another vitamin K dependent protein, and one that we're familiar with, also blocked by warfarin, interacts with the other 2 TAM receptors. So the TAM receptors, first reported in the 1990s, upregulated in patients with cardiovascular disease. There are agonists that are beneficial when they bind to these receptors, but there's also GAS6, which drives cardiac remodeling in heart failure, which drives smooth muscle cell proliferation and migration and stops smooth muscle cell apoptosis. Here we have a mechanism that could explain why warfarin is better than rivaroxaban in this population of cardiovascular disease. Now, if this were true, one might have expected to see this in previous trials of warfarin in cardiovascular disease. Of course, most warfarin trials were not as large as Invictus and did not involve as long a period of follow-up. But there is another piece of less direct evidence to implicate GAS6 in the story of warfarin superiority over DOACs in cardiovascular disease. And this reminds us that GAS6 signaling is upregulated not only in cardiovascular disease, but also obesity. And here are some as yet unpublished, but accepted data, accepted for publication in Circulation from a different setting. This is atrial fibrillation. And this is trials that compared warfarin with DOACs. And this is a secondary analysis that explores efficacy and safety by BMI. So as we go from a BMI of 20 to over 45, there is a clear separation between warfarin and DOACs. DOACs retain their superiority across the spectrum of BMI. That is also maintained in ischemic stroke, although somewhat attenuated for ischemic stroke. The bleeding advantages do disappear for major bleeding, but for intracranial bleeding, a big contrast remains. But net clinical benefit, the curves cross. And when we look at the drivers of this crossover, it's all related to mortality. And when we look at the types of deaths that are in excess in people on DOACs, the types of deaths that are prevented by warfarin, they're almost entirely heart failure and sudden death. And suddenly we see GAS6, rheumatic disease, GAS6, atrial fibrillation with obesity. Maybe warfarin confers its benefit by blocking GAS6, by reducing the activation of the TAM receptors, by reducing cardiac remodeling, by reducing the effects on smooth muscle cells. And this could also explain why the effect is delayed. So watch this space, but this may be the unifying story for rheumatic mitral stenosis as well as for obesity. I want to turn to the fourth area, to the frail elderly. And those of you who follow this literature will have seen in Circulation late last year the results of a Dutch trial that compared staying on warfarin with switching to a DOAC in elderly patients with atrial fibrillation who were previously stable on the vitamin K antagonist therapy. And here is the logo of the Frail AF trial. This was an open label trial, very carefully conducted by folks in the Netherlands. The trial was stopped early because of a clear excess of bleeding in the DOAC group, something that was entirely unexpected. The trial included people over the age of 75, a median age of 83, with atrial fibrillation, with preserved renal function. They were randomized to staying on a vitamin K antagonist or switching to a NOAC. The main outcome was safety, but as I said, stopped because of excess bleeding in the DOAC group. This just reminds us that in addition to being an elderly population, they were certainly frail. This is the Frailty indicator score of 4, which means these were certainly frail. These were also at high risk of stroke with a median CHADS-VAS score of 4. And most people were switched to rivaroxaban. And that may be relevant as we look at the data in a moment. Around 5 or 6% of people got off-label dose reduction. And just to say it up front, this did not explain why we saw the results that we did. In fact, if we'd seen a lot of off-label dose reduction with NOACs, we might have expected to see less bleeding on the DOACs, but we saw more bleeding on the DOACs. And here is the main result. Warfarin, DOAC, cumulative incidence of the primary outcome bleeding. Warfarin much safer than DOACs. DOACs, a 69% excess of bleeding. The subgroups, completely consistent. There is no obvious explanation. How do we explain this result? Is it because they're a really old population who weren't studied thoroughly in the registration trials? Is it because they were stable on a vitamin K antagonist and managed by specialist clinics in the Netherlands? Perhaps, but we don't think that the INR control at these clinics was so good that it could explain a 69%, the 69% excess of bleeding with DOACs. There are various other potential sources of bias that have been proposed, but none of these fully explain the results. It's possible that the dominant use of rivaroxaban in part caused the excess bleeding. We know that rivaroxaban is not only the only DOAC that doesn't reduce major bleeding with warfarin in randomized trials, but it is also one of 2 DOACs which has a significant excess of bleeding in the elderly, whereas apixaban and edoxaban have a significant reduction in bleeding. So this certainly might be part of the story. Bottom line, the best information we have in 2024 is that if you've got an elderly patient who's stable on warfarin, think twice about switching them from warfarin to a DOAC. Even though we're tempted to do so, we think we're going to see less intracranial bleeding, but maybe we're actually going to see an increase in bleeding if they're stable on warfarin and are switched. I'll touch now very briefly on the last category, just one slide to show you that it's not just these categories, but we need to think carefully about people who have breakthrough events on DOAC therapy. And this analysis was done by one of our fellows, Alexander Benz, and he went to the combined AF dataset. This is a dataset of all the 5 major trials of DOACs in patients with atrial fibrillation. And he looked at patients who had a breakthrough event despite anticoagulant therapy. He restricted the analysis to those who resumed anticoagulant therapy after their stroke, and he reported 2 major findings. The first finding is a very high rate of recurrent stroke despite staying on an anticoagulant, around 8% at 1 year, around 12% at 2 years. So that's the first finding from his analysis. The second finding from his analysis, and this was published in 2023, was that if patients were put on warfarin after their event, they seemed to fare much better than if they were kept or switched to a DOAC. And what might be the explanation? This is purely speculative, but it's possible that this identified a group of patients who on a DOAC had subtherapeutic levels. We don't know that, but it certainly raised the question that in these patients also, warfarin is a winner. So it's a very different story in 2024 than it was in 2008 when the DOACs first emerged. It's certainly a very different story to what I had anticipated when we wrote that paper in 2012 suggesting that warfarin is dead. Warfarin is not only very much alive and kicking, but it's actually a winner in mechanical valves, in antiphospholipid syndrome, in rheumatic atrial fibrillation, probably in the frail elderly, and perhaps in people who have a breakthrough event on a DOAC. The second part of my presentation is very brief, and I just want to very briefly add to what we've heard about DOAC failures to identify additional unmet needs in anticoagulation. And there are certain unmet needs where DOACs are unproven, for example, advanced kidney disease. What we've learned from small randomized trials of DOACs in hemodialysis is that they don't seem to be living up to their promise from the observational studies. In particular, apixaban seems to be no better than warfarin, although very small studies, and apixaban as well as rivaroxaban associated with high rates of bleeding. I don't think DOACs are the answer in advanced kidney disease. A couple of other areas where DOACs are unproven, although we tend to use them. The other big areas of unmet need are where DOACs are contraindicated. The most important is people at high risk of bleeding, people with drug-drug interactions, and people with liver dysfunction with coagulopathy. Now, why did I put these in bold? The reason is that I think there is a potential for the factor 11 inhibitors to address each and every of those unmet needs, and perhaps also to overcome some of the DOAC drug failures, particularly when mediated by activation of the contact pathway. So this is where we are in 2024. We've seen the first 3 generations of anticoagulant, and we're looking forward to potentially a 4th generation, or should I say, a 2nd generation of direct oral anticoagulants. The anti-11A or the anti-11 drugs that are most advanced in development, abelacimab, asundexian, and milvexian. But there is a problem, because the phase 2 trials, I'd suggest, are not as promising as we thought they would be. And it leaves a big question mark over whether these drugs will actually live up to their promise. Now, if we were to list the ideal characteristics of a new class of anticoagulant, we'd want them to retain the practical advantages of DOACs, that we could give them in fixed doses without monitoring. We'd want them to be effective where current DOACs are relatively ineffective, contact pathway, mechanical valves, antiphospholipid antibody syndrome, of course, potentially rheumatic mitral stenosis or the frail elderly. But let's start with this particular part here. We'd like them to have a low potential for drug-drug interactions. We want them to be non-renally cleared. And perhaps most importantly, we want little or no bleeding. The beauty, at least the potential beauty, of factor 11 inhibitors are they target the contact pathway. They do have a low propensity for drug-drug interactions, particularly the parenteral agents. They are not dependent on kidneys for clearance, particularly the parenteral agents, but also the small oral agents, relatively low dependence on renal function for clearance. And for sure, they have a lower risk of bleeding. Now, what's the basis for evaluating the 11 inhibitors? And the most important basis is the epidemiologic data with inherited factor 11 deficiency. We've heard the hemophilia story. People with inherited 11 deficiency have very low rates of spontaneous bleeding. They have lower rates of venous thrombosis than people with normal levels, and they have lower rates of stroke than people with normal levels. So the epidemiologic data seem to be pretty consistent and very promising. We have support from experiments in animals, and in 2015, an orthopedic thromboprophylaxis trial supported this promise by demonstrating that the factor 11 oligonucleotide given preoperatively was more effective than standard therapy, or as effective than standard therapy for the prevention of VTE, but was associated with very low risk of bleeding. Now, how can we explain the potential for factor 11 inhibitors to prevent thrombosis for bleeding without causing bleeding. And let's go back to the coagulation pathway. You'll recall we have an extrinsic pathway, the tissue factor pathway. We have an intrinsic pathway, the contact pathway. They converge on factor 10 and factor 2, which in turn leads to both hemostasis and pathologic thrombus formation. When we look at these pathways, we say it's inevitable. If you block this pathway anywhere, we would expect to cause bleeding and prevent thrombosis. But is there a potential for 11s to dissociate bleeding from thrombosis? Well, let's consider what drives activation of the tissue factor pathway. And there are two main drivers. There is an extravascular effect, for example, vessel injury and trauma, but there's also a possible intravascular activator of the tissue factor pathway, which occurs after plaque rupture. If we have extravascular injury, such as in trauma, we get intense thrombin generation, which leads to hemostasis. If we then give a conventional anticoagulant, we block this pathway and we lose our hemostasis. We get bleeding. That's the easy bit. Now, if we get intense vessel injury and drive thrombin generation and we get hemostasis, we don't involve this pathway, and therefore drugs that target factor 11 have little effect on hemostasis because this amplification loop is uninvolved. This contact pathway is relatively uninvolved. So this is why factor 11 inhibitors might not cause bleeding. But what about thrombosis? Here we have intravascular plaque rupture activating the tissue factor pathway. We get thrombin generation, but it's only a modest thrombin burst. And the only way we get to pathologic thrombus formation is through amplification of thrombin generation. So here, if we block using conventional anticoagulants, we block both hemostasis and thrombosis. But if we block factor 11, we retain the ability to achieve hemostasis. We only block this amplification pathway, and therefore we have the potential to prevent thrombosis without causing bleeding. So this is the fundamental basis for believing that drugs that target 11 can prevent thrombosis without causing bleeding. There is an additional potential benefit because if we selectively block the contact pathway, we may be able to prevent coagulation activation from mechanical valves or extracorporeal circuits, LVAD devices, dialysis circuits, bypass circuits, interventional cardiologists putting catheters into people. It really is a very exciting potential if we could block this, but retain hemostasis through the tissue factor pathway. That potential is shown again here, just to remind us, an extravascular injury, large thrombin burst, hemostasis, intravascular injury, plaque rupture, small thrombin burst, amplification needed to get large thrombin burst, to get thrombus, block the factor 11, the contact pathway. We block the formation of thrombus, but we can still achieve hemostasis when there is extravascular injury with a large thrombin burst. So what's the evidence for the randomized trials? I've summarized the trials here. 4 areas where factor 11 inhibitors have been used: venous thrombosis prevention, atrial fibrillation, stroke, MI. The phase 2 trials, I'll summarize for you in a moment, but in most cases, they prevent thrombosis and they reduce bleeding. But there are 2 important exceptions, and the 2 important exceptions are from phase 3 trials, 2 phase 3 trials, the Oceanic AF trial and the Azalea-TIMI trial, both of which were stopped early. So let me go to Azalea first very briefly. This is a phase 2 trial, stopped early because abelacimab at both doses was safer than rivaroxaban, not powered for efficacy. Relatively small trial, 1,200 patients. The abelacimab doses 150 milligram and 90 milligram. And if we look at factor 11 inhibition, virtually no difference, 99% versus 97%. Here are the results. Rivaroxaban bleeding, abelacimab, 150 milligrams bleeding, abelacimab 90 milligrams bleeding. So there seems to be a contrast, even though it's 97 versus 99%. And here we have the efficacy data. Rivaroxaban 1% stroke or systemic embolism. Abelacimab 150, not significantly different. Abelacimab 90, 1.4%. Not significant. But this is somewhat troubling. A 45% increase in stroke could be the play of chance, but there is a dose response. It fits with the bleeding, and we'll see later, this is not incompatible with what we've seen in other factor 11 trials. Now, that's the first study that was stopped early. Abelacimab is going on with a large phase 3 trial in AF, with 2 phase 3 trials in cancer. The asundexian program, the AF trial, was stopped early. Why was it stopped? Well, it was stopped because of lack of efficacy. The milvexian trial program in AF, stroke, and ACS is ongoing. So 2 stopped trials in AF. This is the report from Bayer. Oceanic AF, we don't have the data, but the IDMC stopped the AF study due to inferior efficacy of asundexian versus control. What's the possible explanation? Is it the play of chance? Probably not. I'm guessing it's a pretty robust result for them to have stopped it. An 18,000 patient study. Is it an inadequate dose of asundexian? From the Azalea study, maybe 97% versus 99% is important. But if they'd pushed the dose, would the bleeding have been excessive? Or is it an incorrect hypothesis? Is it really feasible that an 11 inhibitor will prevent thrombosis as effectively as other agents, but not cause bleeding? If we look at a factor 11 meta-analysis that doesn't include Azalea-TIMI 71, here is the key comparison: a direct oral anticoagulant versus an 11 inhibitor, mainly AF, less bleeding, similar or maybe less major bleeding, but a trend towards excess thromboembolic events. Now, we won't know the answer to that until the end of the phase 3 trials, but I think there's certainly space to be cautious. Let me conclude. I think it's obvious that the DOACs are a truly remarkable advance in therapeutics, and they will continue to be prepared for most patients with AF or VTE. But we now know that warfarin is not dead. Indeed, it retains a role in selected patient settings: mechanical valves, antiphospholipid syndrome, the frail elderly, possibly rheumatic atrial fibrillation, and maybe the upper extremes of body weight, and maybe those who have breakthrough events on a DOAC. We certainly need to understand better the mechanisms for DOAC failure, and ongoing trials of factor 11 inhibitors will further clarify whether the hype translates into real benefits for patients. And I'm going to stop there, and I thank you for your attention, and I'm very pleased to take any questions.
Thank you so much, Dr. Eikelboom. That was a wonderful talk. Really hit on all the areas that I was interested in clinically. We'll throw the talk open to questions. We'll look at to see what comes in on chat, and any kind of one who wants to speak up, please feel free. I see that we have one question, and oh no, it's not a question. It's just a comment. I have a question. When you look at all the large atrial fibrillation trials, you spoke about how DOACs in heart failure may have a signal of harm with the gas-6. When you look at all of those large populations, is the subgroup of patients with heart failure, is there any signal there that can be detected at all?
Yeah, it's a great question. I haven't managed to extract the data on heart failure, the subpopulation from heart failure. The most important ones, of course, are those from the combined AF data set. And that's certainly something we need to do, although they're also rather modest size. And I don't know whether it's just having the heart failure or it's the heart failure with obesity. Presumably, it's a combination of these factors. So, you know, the gas-6 hypothesis is intriguing, but it is only really a hypothesis, and it needs a lot more work. We need to look at external data from other trials. We also need to look mechanistically. And if I could take the liberty, I see there's a question about other inhibitors of gas-6. All we really know that's currently available is vitamin K antagonists, but there is talk about using specific antibodies to target gas-6. So there's certainly a prospect for alternatives, but maybe we need a little bit more mechanistic work to prove this. I've simply put this forward as a hypothesis, the only hypothesis that I can reasonably propose as an explanation for what we see in rheumatic heart disease.
Wonderful, thank you. Any other questions in the audience? Speak up or type into the question. Catherine?
Do you have to be therapeutic with the warfarin to get the benefits of inhibiting gas-6?
Yeah, good question. I wish I knew the answer. As I said, it's really a very preliminary hypothesis. I don't know whether you need to be therapeutic. One can't help but think that any degree of inhibition of gas-6 might be of benefit. It would fit with the story that we all have patients who have erratic INR control, subtherapeutic INR control, and yet seem to go on with little or no complications. And I've always wondered, is that because we're just getting a little bit of inhibition of thrombin generation, or is there some other benefit of vitamin K antagonism? I think the effect on gas-6 is a slow effect. I think and that would fit with the crossover of the curves at 18 months. So maybe just having some vitamin K antagonism on board is a benefit. But I can't say that definitively. It's really a hypothesis that I'm putting forward.
Well, my elderly mother always refused to switch to DOACs from warfarin, and maybe she made the right choice. So I guess
yeah,
that's
I think
the message.
That may well be so. We will see in the near future, I think we'll see the emergence of a number of secondary analyses of existing trials that try to either replicate or refute this the conclusions of frail AF. There are going to be some conflicting findings, and so we're going to have to go back to investigate this further. But I would agree that based on what we know today, my level of caution about switching someone who is really well controlled, even if they're elderly, has certainly gone up. In the past, my threshold for switching was very low. If I wanted it, I just flipped them. Now I'm saying, well, maybe you should just stick to what you're doing.
Well, we are at the top of the hour. I'd like to thank you very much for coming in and joining us. That was a wonderful talk. And I look forward to running into you at the meetings. Thanks very much, Dr. Eikelboom.
My pleasure. Thanks very much.
Have a good day, everyone.